Welcome to Learn with Longevity and UChicago Medicine. A special hello to all the lung cancer patients and survivors joining us virtually from Chicago and from around the country. My name is Lauren Humphreys. I am Longevity Foundation's Associate Director of Constituent Engagement. Longevity is the nation's leading lung cancer nonprofit, and we are transforming what it means to be diagnosed and live with lung cancer through research, advocacy, and support. Our partner today, the University of Chicago Medicine Comprehensive Cancer Center, is internationally recognized as a leader in cancer care, research, and education. Today, you'll hear from some of their internationally recognized experts about the latest in lung cancer treatment and ways to navigate your diagnosis. This is a virtual learning event intended for patients and caregivers, so the session is informative in nature only, and our staff and the expert speakers cannot offer medical advice. Please consult your provider and healthcare team about anything and everything you learn here today. Please use the Q&A feature to ask any questions during the program and use the chat to provide comments and feedback. We will have a group Q&A after all of the presenters have finished. Our longevity team is monitoring the chat in real time, and we will strive to answer all of your questions. We are thrilled to have several experts from UChicago Medicine today. At this time, I'd like to invite Dr. Garasino, Professor of Medicine and Thoracic Program Director, to introduce their team so they can begin their presentation.
So hello, everyone, and thank you for organizing these important moments with the patients and also with the population that I think are very informative for all of us as doctors, and I hope for the patients. It's a great pleasure for me to chair with session also with Dr. Donington, and I'm happy also to introduce all the people of our multidisciplinary tumor board. We discuss all the cases for all the patients always together, and this is, I think, that is the strength also of this event. So the first will be Dr. Tawani. Dr. Tawani recently joined the University of Chicago, is an assistant professor working in our program. Dr. Hines is a brilliant fellow of the last year, again, in the thoracic program at the University of Chicago. Then we will have Dr. Lucia Madariaga and in the surgery program, and Dr. Aditya Julori, who is our fantastic radiation oncologist working in the Department of Radiation and Cellular Therapy. I just want to introduce also Dr. Donington. Dr. Donington is a worldwide known surgeon and working in our multidisciplinary tumor board, and I'm happy to introduce also her.
Thank you, Marina. It is a pleasure to be here. Longevity has been a long friend of the University of Chicago, and we love these lunch and learn events. It's a great way for us to speak to our patients and for all of us to learn more about what we do. I think lung cancer is in such an exciting time. So much is changing. Cures are becoming more common, but that also means it might be becoming a little more complex to deliver care, and it's definitely a full-on team sport. Almost everyone who we treat now needs all of us to be involved, so it's always nice when we can be together.
Thank you, and I think that we can get started with the first presentation about the importance of biomarker testing, and take it away.
Thank you, Dr. Garcia. So I'm Rajat Tawani. I'm going to talk about the importance of biomarker testing. I will start off with just, my disclosures first. So I have no relevant disclosures. I'll start off with explaining what a biomarker is. As you can see, it's the merger of the words biological and marker. So these are basically markers or molecules that are measured in tissue, blood, or other bodily fluids. Now, these mark a sign of an abnormal process or a condition that might be ongoing in the body. The most common ones that we see being used are PSA, for example, for prostate cancer, BRCA1 or 2 gene for hereditary risk for breast cancer. We'll talk briefly about circulating tumor DNA, in the subsequent slides. And then hemoglobin A1C is also a biological marker for diabetes, which is also very commonly used. So as I said, biomarkers have different uses. The 4 uses I'm going to highlight are determine whether a disease is present or not. So they can differentiate between a disease being present or absent. The second one is how aggressive the disease is. For example, HbA1c is a number that is a biomarker for diabetes. The higher the number, the worse the diabetes is. So biomarkers can be used as a gauge to see the aggressiveness or the severity of the disease. In addition, they can also predict response to a treatment, and then we'll go further into this especially in lung cancer. And we can also monitor treatment or response to treatment or predict recurrence of cancer, for example, using biomarkers. In lung cancer patients, biomarker testing helps us understand what treatment would be best for patients. Presence or absence of biomarkers affect treatment of lung cancer, specifically PD-L1, which is a protein which is expressed on cancer cells. So staining these cells with PD-L1 can tell us how well patients will respond to immunotherapy, for example. The other kind of biomarker that we test for in lung cancer is genomic testing, which is testing the genome, which is the DNA and the RNA of the cancer cell. Now, we can do it in 2 ways. One of them is the tissue. So whenever there's a biopsy to diagnose the cancer, we can extract DNA from the tumor to look at the genome of the cancer, or using liquid biopsy, which is circulating tumor DNA, where the tumor spills DNA into the blood, and we can catch that using liquid biopsy, extract DNA from the blood, and do genomic testing on that specific DNA. How does it work in the background? So as we see people who have a diagnosis of lung cancer, we can take a sample. Now, again, the sample can be blood or can be tumor. It goes to the lab where our pathologists extract DNA from the specimen, and then it goes through the machine to sequence the genome. After that, it feeds the genome into a computer to kind of figure out what biomarkers are present in that specific sample. And then that report comes to us with the patients, and then we decide what is the best treatment for that patient, which is the basic framework of personalized therapy in lung cancer. Who should receive biomarker testing? I think it's a broad question. It's a very nuanced question, but broadly, I think all patients diagnosed with non-small cell carcinoma, for the most part in the US, get biomarker testing of some kind. They could be from stage 2, 3s, and 4s, sometimes stage 1, irrespective of their smoking status. And then, especially if we find a positive biomarker initially, once the cancer comes back, it is strongly recommended that we do biomarker testing again in those patients. Whereas in small cell lung cancer, biomarker testing is not as advanced as non-small cell and is usually used only in clinical trials. The other aspect of biomarkers is how long do you wait for your results? And waiting is a challenging necessity for patients and oncologists in determining what the best treatment for these patients are. So liquid biopsies can take a couple of weeks, and tissue biopsies can take a few weeks, depending on the complexity of the tumor and the genomic changes. And again, the results, as I said, determine what treatment you get. So PD-L1 determines treatment between using immunotherapy only or adding chemotherapy to immunotherapy in lung cancer. And the table on the right shows us what genomic sequencing can help us with. So having different genomic changes in the cancer DNA, we have different drugs available for these patients that are usually used either right away, avoiding chemotherapy altogether, or after patients progress on chemotherapy. So I have a case scenario just highlighting some of the nuances. So For example, we have a Ms. Doe, 65-year-old woman with a remote smoking history who was found to have chest pain and cough. Now, these are the patients that are more predisposed to having genomic alterations and having targeted therapy as an option for them. So Ms. Doe got a CAT scan that revealed multiple lung nodules and got a PET scan, which confirmed that the disease is stage 4, so it's outside of the lung. She got a biopsy, which confirmed lung cancer, and genomic testing was performed on the tissue. Now, one scenario would be that the treatment is started without waiting, and chemotherapy and immunotherapy are started, and 3 weeks later, an EGFR mutation is detected, which comes in the genomic test. And then she's transitioned to a pill, which we know works better for patients with EGFR. Unfortunately, with the pill given after immunotherapy, there can be bad side effects. So this, if she had biomarker testing and we waited for the right biomarker before starting treatment, we would have started Tagrisso, which is the drug for EGFR mutation, right away, and we would have avoided pneumonitis or bad lung disease that happens when we give Tagrisso after immunotherapy. So that would be the right approach. And for patients, I think one of the frequently asked questions before testing for biomarkers is who is doing these tests? What are the complications from these tests? And will insurance pay for these tests? And I think it's important to discuss these questions with your doctor. And after testing, if the test results are not clear, should you get retested waiting longer for results? And do you need to get these tests again? And do these tests mean that there are clinical trials available? So that's my last slide. I'll address all the questions in the Q&A, but I'm going to introduce Dr. Jacoby Hines, who is a senior fellow in the section of Heme/Onc in the University of Chicago. I'll hand it off to him.
Dr. Jacoby, you're muted.
Thank you. Thank you. Sorry about that. I'll be talking to you guys about patients who have immunotherapy prior to surgery. And so just as a basic outline, we'll be going through kind of the basics. What is immunotherapy? Why do we give it? How do we give it? How do we decide which patients are going to get immunotherapy? Any potential side effects from immunotherapy, and go over some reasons why immunotherapy might not be the right choice for everyone. So I think we're all familiar with the immune system in any context, but wanted to lay some groundwork to discuss what we're going to talk about later. So the immune system is a collection of cells, tissues, and organs that protect the body from anything from the outside. So we have physical barriers like the skin and the mucosa that just protect anything from getting inside. And often we mostly think about white blood cells, which are made in the bone marrow, float around through our bloodstream and attack, again, anything foreign. We typically think of them fighting bacteria, viruses, etc. In addition to kind of moving around the bloodstream, looking for foreign invaders, certain white blood cells can set up in the spleen and lymph nodes that act as sort of almost like way stations or border control throughout the body as they surveil for abnormal cells and report them to the rest of the body. And again, we think of the immune system mostly as fighting infections, but they also look for basically any abnormal cell in the body. And part of that is looking for early cancer cells. And so what is immunotherapy? It's basically any medicine that helps the body do that job to find and attack cancer cells. And really over the last decade, it's changed how we treat a variety of cancer types used in almost every cancer nowadays. The most common type of immunotherapy is something called an immune checkpoint inhibitors. Here listed are maybe some of the common ones that you might have seen commercials for, such as Keytruda, Opdivo, and Yervoy. And how exactly do they help the body fight the cancer? So if you look at the picture on the left, the big yellow cell at the top is a tumor cell. The blue cell at the bottom is a T cell, which is part of our immune system. And here the T cell is trying to attack the tumor cell, but the tumor cell is sending this signal, basically saying, don't attack me. It's a signal that normal cells in our body have so that our immune system doesn't attack them. And the tumor has learned to send this signal to the T cell saying, don't attack me, I'm a normal cell. So what these immune checkpoint inhibitors do is they stop this don't kill me signal and basically allow the T cell and the immune system to go after and kill these tumor cells. And so why do we give immunotherapy? Pretty simply, it's shown to improve responses in patients when given with chemotherapy, especially in the setting of patients getting surgery. And so it improves something that we call pathologic response, which is after surgery, we're looking at the specimen under the microscope and the pathologist is seeing less tumor when immunotherapy is given compared to when it's not given. And similarly, when immunotherapy is given with chemotherapy, it reduces the chance of the tumor getting bigger or the tumor coming back if it's gone away completely. And again, as I mentioned, in most circumstances that we're discussing, it's going to be given with chemotherapy. It's also administered through the IV with the chemotherapy and usually given once every 3 weeks. And patients who we think are most appropriate for immunotherapy, generally patients with larger tumors greater than 4 centimeters, patients who we suspect or know have disease in their lymph nodes. And again, in the context of what we're talking about today, it's patients we've already come together and decided that they're an appropriate person to get surgery. And so the schedule looks like this. After we've come together in a multidisciplinary tumor board, discussed the case, we've decided the patient is someone who's a surgical candidate. They've met some of the criteria I discussed in the last slide. They're going to get chemotherapy and immunotherapy before surgery, which is something we call neoadjuvant therapy. And again, it's given about once every 3 weeks for about 3 to 4 cycles. So you're looking at a couple months of therapy prior to the surgery. Then you get the surgery, and then after, you may get additional therapy called adjuvant therapy. The exact type of adjuvant therapy and how long you're going to get it is going to depend a little bit for each patient. This is an area of pretty active research amongst lung cancer, and so really does require another sort of multidisciplinary discussion about the exact ways to move forward. But what should you expect from immunotherapy? So unlike traditional chemotherapy, which works by basically attacking any cell that's dividing very quickly and can't discriminate between cancer cells that are growing very quickly or hair follicles, cells in the GI tract, and will sort of kill all those cells, which is why you get symptoms such as diarrhea, maybe nausea, as well as hair loss. As we discussed before, immunotherapy is really just targeting the immune cells and helping the body itself attack the cancer cells. So generally has a lot less side effects than you may associate with traditional chemotherapy. But immunotherapy does indeed have its own unique set of potential side effects as well. As we've discussed, the whole point of the immunotherapy is to activate the immune system, block those checkpoints, and get it to attack the cancer more effectively. But again, as I discussed, those same signals are ones that are used by our normal cells to say, don't attack me. So there's a chance that the immune system can become overactive in a way and cause inflammation. And it can really happen in any organ, as you can see on the left there. It can affect, you can get inflammation in the lungs, causing pneumonitis, inflammation in the colon causing colitis and diarrhea, or inflammation in the thyroid. Generally, these side effects are pretty rapidly reversible with high-dose steroids. Sometimes you may have to stop the immunotherapy. And generally, for the most part, we would discover these through lab values. So we're monitoring lab values to see if the thyroid function has changed, or if there's some signs that the liver may be inflamed. But also, again, as I discussed, patients would let us know if they're having any symptoms like cough, trouble breathing that would suggest inflammation in the lungs, or diarrhea that was just inflammation in the colon. Generally, about 1 to 2 out of every 10 patients would have a side effect that's bad enough that we would have to stop treatment and give them steroids. But again, most of these are pretty quickly reversible with the use of steroids. And so why might we not give immunotherapy? As I mentioned, the whole point is to, really rev up and activate the immune system. But in patients who have conditions in which their immune system is already sort of attacking certain parts of their body, that is autoimmune diseases, there is the risk of worsening those autoimmune diseases. So common autoimmune diseases would be inflammatory bowel disease, lupus, multiple sclerosis, or rheumatoid arthritis. If you have any of these conditions, doesn't necessarily mean you absolutely can't get immunotherapy, especially if they're well controlled, but it is something to be aware of. Let your oncologist know if it's not already been divulged that you have one of these conditions. And often it requires, again, a team approach working with usually the rheumatologist or whoever is helping manage autoimmune disease to make sure that things are well controlled and minimize the risk of it flaring up while you start the immunotherapy moving forward. Similarly, sometimes if patients have pretty significant lung disease, particularly interstitial lung disease or ILD or uncontrolled asthma, may give us sometimes some pause if we want to, again, give immunotherapy and risk the possible side effect of severe inflammation in the lungs when the patients already have pretty poor lung function to begin with. And then, as Dr. Thawani had just talked about, certain lung cancers have certain mutations that drive or cause the cancer. And in these mutations, immunotherapy may not work as well, or as Dr. Thawani mentioned, may actually increase the risk of side effects if a targeted therapy is given later. So there may be some instances in which patients may not get immunotherapy. So in summary, adding immunotherapy to chemotherapy before and after surgery has shown to improve outcomes in patients in terms of more of the cancer going away and a longer time before it comes back or gets bigger. And again, it can be given before and or after surgery and is generally well tolerated. And so this is my final slide. And next would be Dr. Madriaga, who's going to talk more about prehab prior to surgery.
Hi, everyone. I'm going to talk to you about how to get ready for surgery. So prehab and lung cancer surgery, as I'm sure a lot of you know, many people undergoing lung cancer surgery are older adults. And as you can see from this pie graph, close to half of the patients with lung cancer are age 70 or greater. So we really need to take care of older adults undergoing lung cancer surgery in a special way. And this is because older adults have a tendency not to recover after surgery very well. The graphs on the left are studies done to look at how patients' functional status are affected with surgery. And you can see there's a big dip in how patients do their normal daily activities, eating, grooming, toileting, dressing. And that takes some time for it to recover back to baseline. And on the graph on the right, you can see a schematic of what this all looks like from a scientific standpoint, where you have some patients who are robust in green, where they can undergo a stress like surgery and really bounce back quickly to how they were. But other patients who are frail, and we'll go into a little bit about what that means, in red, they go for a stressor such as surgery, and they may or may not get back to what their baseline status was, and it might take a longer time for them to get back to how they were before surgery. So this concept of frailty is talked a lot right now because we want to identify how we can help these older patients who have a tendency to have frailty do well with surgery. because we know that frailty increases complications, prolongs your length of stay in the hospital, have higher rates of discharge to other places than home, and has very poor outcomes for patients undergoing surgery. In fact, thoracic surgeons came together as a group and said frailty is the #2 most important thing as a risk factor for undergoing lobectomy for lung cancer. So everyone's on high alert. We did a national survey of thoracic surgeons to see what they felt about frailty and what to do about it. And you can see here from these graphs, close to 70 to 80% of thoracic surgeons nationwide felt that we should be finding frailty in our patients if it exists, and we should be doing something to mitigate frailty in the preoperative setting. 50% of patients 50% of surgeons who we surveyed actually prescribed prehab, and we're going to get into what prehab means. So prehab is a short term for prehabilitation. It's a process by which the functional capacity or capability of a patient is improved before your surgery, so that whatever happens in the course of surgery or afterwards, you're able to bounce back to baseline.
You good?
This was advocated for by lots of surgery societies, including the American College of Surgeons. And they have started instituting programs to help hospitals and clinicians start helping older adults get through surgery safely. One of the problems with prehab is that there's so many different types of prehab that exist. You can prehab a person based on exercise, their nutrition, education, giving them mental or psychological support, and lifestyle modifications, as well as modifying their medicines. So lots of different programs for prehab exist, and no one's really quite sure which one is the best yet. But overall, if you take a look at all the studies, you can see that prehab before lung cancer surgery improves your ability to exercise through some tests that we call VO2 max and 6-minute walk distance. It improves patient-reported outcomes through surveys of quality of life, and it also improves clinical outcomes such as postoperative complications and how long you stay in the hospital. Well, that's really good news, but now we need to take prehab out of the clinical trial setting where it's studied very rigorously and into the day-to-day, I'm going to my surgeon's clinic and what do I do? Because participation and adherence to prehab can be quite low. So the first thing that we're taking part in this research as well is we wanted to figure out how to improve prehab participation. And what we did is a qualitative study, meaning we asked patients and we asked providers from thoracic surgery what you need for prehab to actually happen in your clinic. And so we organized information based on the 5 rights. So the right information, people want to know what's the beneficial impact of prehab on recovery, on your quality of life, on your health. The doctor is a very important person in needing to prescribe the prehab and say that it's very important for their plan of care. The concept of prehab should be introduced early. So your first time that you are in contact with your lung cancer doctor, if surgery is on your treatment plan, you should be thinking about prehab and what you can do to optimize your functional capacity. And then how do we deliver prehab? Well, I think it depends on the type of person you are. Some people are very tech savvy and they want to use a wearable tracker. Other people prefer pen and paper and they want a piece of paper that will help them go through exercise and nutrition and daily diary logs, etc. So that's very person specific. And that also goes along with the right format. And I think that's where the research is going now, is try to discover how in different specific instances in all the pockets of the United States, how can we deliver prehab in a way that patients will actually go through with it and use it. So here are some parting thoughts about prehab, and willing to answer any questions in the chat at the end. Prehab is definitely recommended to optimize older, frail adults for surgery because it enhances your resiliency, so the opposite of frailty, and it prevents that functional dip or decline that you get with surgery. One issue is that the prehab protocols are not standardized, so you can't say this is the one that, rules them all. And what we need to address right now with research is the challenges facing implementation of prehab, so everyone who wants prehab has access to it and can do it. Thank you. And now I'm going to introduce Dr. Aditya Jaluri, who will give his talk.
Hello, everyone. 1 second. Let me share my screen. All right. So my name is Aditya Jaluri. I'm a radiation oncologist here at the University of Chicago, and I've had the pleasure of doing this a couple times now. And the last couple times we went over some of the basics of radiation for lung cancer. So I'm going to go a little bit more advanced today, and I certainly will be happy to answer questions at the end. I know that we have a really engaged audience, and the longevity group is very well connected to the lung cancer world, but certainly happy to clarify some of these things at the end if we need to. I've been tasked today to talk about radiation and immunotherapy for lung cancer, specifically non-small cell lung cancer, which, as we know, is the most common type of lung cancer here in the United States. So really today, I want to talk about two different types of lung cancer in which we use radiation. One is locally advanced lung cancer, or lung cancer with lymph nodes, for patients who are not getting surgery. The other one is for metastatic non-small cell lung cancer. And I know there was a question in there about oligometastatic disease, so we'll touch upon that a little bit as well. So we know, thanks to Dr. Tawani's and Dr. Hines' talks earlier, that immunotherapy is very important now for patients with metastatic disease with non-small cell lung cancer. And we're trying to determine, we know that immunotherapy works for patients with metastatic disease. How do we best use it for patients with stage 3 disease or stage 2 disease? That's been better established now for patients getting surgery, as Dr. Hines nicely reviewed. But what about patients with stage 3 lung cancer that are not able to get surgery, either because of how advanced the disease is or how many lymph nodes there are, or because of health reasons and frailty, like Dr. Madriaga reviewed, that not everyone can get a surgery. So how do we incorporate immunotherapy with chemotherapy and radiation for lung cancer with stage 3 disease? So this is an important trial that many of you might know about, which is the Pacific trial, which came out about 5 years ago now, in which, actually longer than 7 years ago now, I think, the initial study, in which patients who had unresectable stage 3 lung cancer got chemotherapy and radiation. And then we figured out from this trial that giving patients a year of a special immunotherapy called durvalumab actually improved outcomes. And by 5 years out, 10% of the overall survival was significantly improved, with a difference of 10%. So this is, again, giving chemoradiation and immunotherapy after chemoradiation. So how do we improve upon this? One major idea is figuring out if we can bring the immunotherapy in earlier during the chemotherapy and radiation. So this is a trial that has been recently closed, which was for a very similar population of patients with stage 3 unresectable disease that were randomized to chemoradiation or durvalumab, a type of immunotherapy, concurrently with the radiation and then after the radiation. But we recently found out a couple months ago in November that this trial is closed because it did not seem that adding an immunotherapy along with the chemoradiation at the same time actually helped matters. We haven't seen the data yet, but many of us are really actively interested to see why this is. And so what we know, though, is it appears potentially that concurrent immunotherapy is somehow acting in badly, because we already knew that the adjuvant immunotherapy worked. So why is that? Well, we have to also think about other disease sites. In head and neck cancer, advanced head and neck cancer, we've done very similar trials. We've tried to do concurrent immunotherapy along with chemoradiation, but none of those trials actually worked. Doing immunotherapy at the same time as chemoradiation has not improved any outcomes. And there's a lot of reasons why a lot of us have hypothesized. One possibility, as Dr. Hines discussed also during his talk, was that immunotherapy is essentially these T cell fighters that are in lymph nodes, normal lymph nodes and tumor lymph nodes that are activated to go fight the cancer. But by giving radiation to the lymph nodes at the same time, we may be counteracting the ability for the immunotherapy to work. So, this is an example also from head and neck cancer where they tried to do, okay, well, how do we add in immunotherapy to chemoradiation? Those patients either got the immunotherapy concurrently at the same time as the radiation. So at the same time we're radiating those lymph nodes and maybe hurting the ability for those T cells to work, or giving immunotherapy afterwards. And in this trial, doing immunotherapy sequentially in the green arm, patients did better. So it does not appear that giving immunotherapy at the same time as chemoradiation is likely to be a successful strategy to further improve outcomes for our patients. So from the Pacific trial, right, we know that immunotherapy works, we know that chemoradiation works, and it appears that giving them sequentially or after each other does work, but concurrently, no. So, a lot of us will talk about this idea that radiation can perhaps activate the immune system, but it doesn't seem like we have a really good evidence of that yet. I think what we do know is that these two things work very well, and we need to figure out how to best use them together so that it's 1 + 1 = 2. We know that SBRT or radiation is something that we utilize for stage 1 lung cancer patients who don't have any lymph nodes if they can't get surgery, if their lung function is not good enough to get surgery. So that's a standard treatment that we do all the time here at the University of Chicago and elsewhere in the country. But we have trial evidence now that in patients who are going to get SBRT or focal radiation for early stage lung cancer, if they get radiation alone, or in this trial, they got 4 cycles of an immunotherapy called nivolumab before the treatment. And it turns out that doing immunotherapy and radiation for stage 1 lung cancer actually improves outcomes, because remember, the SBRT works quite well locally where the tumor actually is. But one of the biggest challenges we all face with lung cancer is what's happening elsewhere. Are there any seeds, that I like to call them, or tumor cells that are going to leave the tumor where it initially is and go somewhere else? And that's where it appears to be that immunotherapy can help these patients, our patients. So we also know that in metastatic non-small cell lung cancer, we need to improve outcomes, right? We know that immunotherapy and chemotherapy are very good, and immunotherapy has been a game changer in addition to chemotherapy for our patients with non-small cell lung cancer. But we also know that SBRT works, right? So what about trying to ablate sites of existing disease in our patients that may be early sites of treatment failure, maybe sites that are causing pain or causing airway compromise that can actually even lead to tumor death before patients really even have a chance to really derive the full benefit from multiple cycles of immunotherapy. We also know that in patients with really big lung tumors or really big tumors in general, the tumors themselves can be immunosuppressive, so that by radiating them or ablating them, we can actually, at the start of treatment in patients who are getting immunotherapy, actually potentially reduce that immunosuppression and give our patients the best shot to actually have prolonged responses to immunotherapy. And so the way I think about it, right, is that peanut butter and jelly work best together. And so we're really trying to figure out a way in which 2 treatments that work quite well can work very well together. So the other thing that we know about is that radiation can be very helpful in patients with metastatic lung cancer or metastatic cancers of any type, I would say. This is a very important trial that was published at the end of last year, in which patients who had asymptomatic bone metastases, so we normally would only treat bone metastases that were painful or were already fractured, but in this trial, patients who had metastatic cancers got radiation to certain high-risk bone metastases in particular areas, if they were at risk for fracture, if they were in the spine and there was a risk of causing a cord compression. And in this trial, patients who received radiation to asymptomatic bone metastases actually had fewer hospitalizations and fewer skeletal events. Actually, the trial actually showed an improved overall survival as well in patients who got the radiation to the asymptomatic bone metastases, but that really needs to be tested in a larger trial, and that trial will happen nationally for us to determine, again, where should we be adding local therapy with radiation or surgery, a local therapy of some type in patients with metastatic disease. It doesn't just have to be patients with oligometastatic disease. This is another trial from prostate cancer, but I pointed out because I think all of these different disease sites can help inform each other. In this trial, patients with metastatic prostate cancer got radiation to the prostate along with the systemic therapy they would get otherwise. And in people who got radiation to the prostate, even with metastatic disease, there was fewer interventions for urinary tract obstruction, meaning that we were able to avoid the local problem becoming a problem that affected patients with interventions. So one of the things we really like to do at University of Chicago, I'm very lucky to work with Dr. Donnington, Tawani, Dr. Madriaga, everyone on this call, in helping to design trials to better improve outcomes. This is a trial that we did for patients with metastatic non-small cell lung cancer, in which they did get radiation to different sites at the beginning, along with immunotherapy, and the median survival was 34 months, which is quite promising for our patients. And so we're hoping to further investigate this in future trials. So I think for future directions, we know that stage 3 lung cancer patients, need immunotherapy. It seems that concurrent immunotherapy is not likely to be helpful. One of our theories is that maybe we should be doing neoadjuvant or induction chemoimmunotherapy for our patients, just like we do for resectable lung cancer. That allows us to bring in the immunotherapy earlier, and it also does not mean that we have concurrent therapy at the same time as radiation. And for metastatic lung cancer, we need to determine which subsets should really be getting local therapy along with systemic therapy so that we can further improve outcomes as well. Thank you. And then we'll move this over to Dr. Donnington, who will lead our Q&A session.
So thank you to our whole group. These were really great talks. And I appreciate the expertise of everyone on the group. We had one question in the chat earlier, and that had to do, I think it's worth discussing. It's a very interesting concept in lung cancer right now, and that is oligometastatic disease. It's kind of such a fancy word. And I think one that doesn't make a lot of sense to a lot of patients. But I guess I want, maybe I'll go to Dr. Garasino and just say, you kind of defined it for us in the chat as up to 5. Why do we think we treat these patients maybe different than a regular metastatic patient?
I think that there is, a lot of discussion around this concept because also when we see the trials included, definitions of oligometastatic that are different. But I think that what is in common with all the definitions is the possibility to use local therapies. So, for example, if you have a single lesion in the brain, you can do SRS or the resection. If you have a single lesion in the liver, you can do ablation of the liver or resection again. So basically the consensus is more with the idea that potentially you can remove some of them with several techniques. 5 is a common definition, just that is useful for the consistency in the clinical trial.
This does seem to be a group we see more and more now as our chemotherapies and all the systemic medicines work so much better than they did before. Suddenly this group becomes very real. So now our chat questions are coming up. So I have one for Dr. Thawani, and then we'll go to the one in the chat. So you talked to us about a lot of biomarkers. How do you determine when it's best to use a tissue biomarker versus a liquid biomarker? And what are the pluses and minuses of both?
That's a great question. I think something that we encounter every day. I think the liquid biopsy or the blood-based biomarkers are faster in resulting. I think most of them are commercialized to a point that once we send it out, it comes back in 1 to 2 weeks. The tissue-based biomarkers take longer in resulting. There's more processes that are involved in getting those results out. I think in my practice, we send both of them together. Now, whether that's the right thing or not, we don't know. I think we haven't had any trouble from insurance and billing, which is why we're able to send them both together. I think the good thing is that with the liquid biopsy coming back faster, if there's a positive hit on the liquid biopsy, then we can just start based on that. We don't have to wait for confirmation on tumor. We do wait, but we do get it eventually, but we don't have to wait. If it's negative, then I think we do end up waiting for a tissue confirmation
So
to
is
make
the
it
tissue
negative.
maybe a little more sensitive? They can find a
Yes.
little bit more.
Yeah, I think depending on the size of the tumor, where the tumors are, how much it's shedding, a lot of those play into like what the sensitivity of a blood-based biomarker would be. I think tissue being the gold standard, we do want to wait for it and confirm our findings, but yeah, blood doesn't always work, but if it does, I think it does expedite a lot of different things.
And then within the chat, we have a question about how do you recommend using biomarkers to monitor treatment? Is that something you do, or these things you check all the time?
So in lung cancer, we don't usually do it. We're only getting testing after there's a recurrence or we think that the tumor is coming back. This concept is widely used in colorectal cancer, where the tissue, the biomarkers derived based on what tissue what biomarkers come back in the tissue. But it's not widely used in lung cancer. There's no longitudinal data justifying its use as of now. So yeah, I don't usually use it in my practice unless I'm suspecting that someone is having a recurrence.
Yeah, I think we're all hoping that there might be a day when that circulating marker will be able to tell us when we need to either, add care or maybe even, take care back. But I think, right, for lung cancer, we're not there today. Doesn't mean we won't be there in a year or 6 months. Things change so quickly now.
Yep, absolutely.
All right, Dr. Hines, maybe I'll go to you for this next question. It's even more complicated. If you do this, you may be ready to move on to become an attending right tomorrow. Because it says, how are you using all the advances in precision medicine and genomic advances in treating lung cancer? So we've discussed all these biomarkers, all these different things. When a patient comes into clinic, how do you put this all together and say, this is how I'm going to treat you?
Yeah, I think Dr. Thawani outlined a lot of it in his talk, but a lot of it has to do, again, getting that molecular analysis, because a lot of what we do in treating lung cancer is so driven by those results. So as we talked about, immunotherapy is, really taking off in all these cancer types, and we use markers of, again, PD-L1 to see if patients could get just immunotherapy or combination immunotherapy, chemotherapy. And then as we discussed, patients with certain genetic changes don't benefit as much from immunotherapy and may actually have worse side effects. So that's actually really critical in deciding sort of what next steps to take, or even the initial steps with initial treatment. And then again, with if those therapies were to stop working, kind of doing that assessment again sometimes can reveal new information, new genetic changes that sometimes we can also target with additional agents if they would have, again, certain sort of escape mutations. So really, I think at each part of the process, and as we talked about, maybe even using ctDNA at some point in the future, really informs our treatment decisions along the whole time course of treatment.
I'm going to ask you one more question. So in the surgery population, every time you talked about immunotherapy, it was paired with chemotherapy. Does that always have to happen? Patients don't always like chemotherapy. It has a super bad rap.
I would say, at least for the sort of neoadjuvant before surgery part, we just don't have the data that immunotherapy by itself gives us, as well as outcomes, again, improvements in that response when we're taking out the tumor, as with chemotherapy. Chemotherapy has been used for years before surgery. We know that adding immunotherapy to that is better than chemotherapy alone, but immunotherapy by itself just isn't sufficient. Likewise, in some aspects, like by the way that immunotherapy works, it can sometimes just take longer for it to have a therapeutic effect or to see changes. So that's why combining it with chemotherapy, at least up front, is the best way to go. And again, sometimes afterwards, some of the trials did just immunotherapy afterwards in the adjuvant setting, but upfront before surgery, you really need the combination of the two for the best results.
All right, and I'm gonna go back to you, Dr. Thawani, for a second. You know, we've heard all kinds of fancy names for these immunotherapies: nivolumab, pembrolizumab, durvalumab, atezolizumab, all the MIBs and MABs. Are these medicines all the same? Are they very different? If a patient had one, could they substitute another? How do you make that decision?
Yeah, that's a very common question that we get in clinic. I think some of them are better advertised than the others, so it depends on what you see on TV. So I think there are two broad categories of immunotherapies, the PD-1 and the PD-L1 inhibitors that we use. And then there's a CTLA-4 inhibitor, which is a whole together different category that, I think we use lesser. I think the two broad categories I would say are PD-1 and PD-L1 inhibitors. The way we decide which one to use is based on a couple of things. One, which one has already been studied for that specific indication. I think for the most part, we all believe that they, between the categories, they kind of work similarly and they can be used interchangeably. I think it's the comfort of the treating physician. It's how frequently those are dosed, how many cycles those were, how many cycles of those treatments were given when they were being studied in a clinical trial. So I think there are a lot of nuances in deciding, but if you ask me personally, I think for a stage 4 patient especially, I don't think there's much of a difference. I don't think we'll ever have a day where we study one against the other. I don't think that's ever going to happen. So I can't really prove it, but I do feel that they're probably similar.
Okay, all right. So now, Dr. Jalori, you talked a lot about using immunotherapy kind of in combination with radiation. Maybe not during, as we're kind of learning, which is kind of crazy because for other diseases sometimes that works, but I guess that lung cancer is different than colorectal cancer or breast. But what about patients who have brain metastases? That's such a common thing in lung cancer, and so many of our patients do require, radiation for brain metastasis. How does that fit in if they're also getting immunotherapy?
Good question. I think, one of the things that we talked about a little bit about was the importance of PD-L1 that is not completely one-to-one informative, but can be helpful in understanding how well immunotherapy will work in the body overall. There are some studies that reflect the fact that patients that have a really high PD-L1 score can actually have the immunotherapy also work in the brain. That's similar to other targeted therapies like the EGFR medications that Dr. Thawani was talking about at the beginning that actually do work quite well in the brain. So what I would say is that as our medications get better, they're also working in the brain or working in the body in a way that if you can control tumors in the body, that sort of helps limit the spreading of that tumor to the brain. So overall, that's leading to us having to radiate brain less often. But on the other hand, patients are living longer, and as patients are living longer, when sometimes ultimately the treatments do fail, that does require us to use radiation for the brain. A lot of technology has improved quite a bit so that we don't have to treat the whole brain necessarily and can treat to very, very focal areas in the brain. If we have to treat a larger part of the brain, we're able to do what's called hippocampal sparing radiation, where we're able to spare the memory centers on both sides of the brain. Also, there's medications that are available now that can help better preserve memory. And lastly, we know that the hippocampus is very important in the brain, but there's other things that are important too. So we're working on developing and identifying these other tracks of important areas in the brain that we can better spare. But definitely, I think we are very happy here, at least in our institution, to very carefully select when we have to treat the brain, because there's been times that when Dr. Garcino and I, or Dr. Bisvina and I, or Dr. Thawani and I have discussed the cases, and we believe that the medication that a patient is about to start is going to work very well in the brain, and we actually just watch and get an MRI in a month or so, and then the tumors are gone, and we're happy to. I'm very happy to radiate when I need to, and I'm also very happy to avoid radiation if I don't have to give it. So, good question.
So the discussion of medicines that might work really well in the brain brings me to one of the questions in the chat. I don't know if we spend enough time on targeted therapies. And are those, when you see a patient with a targeted mutation in brain metastases, do we start the medicines first? Do we radiate first? How do we think about that?
Usually, if
Might be
we
for
can,
everybody.
yeah, usually if we can, we like to start with the medications first. I think it sort of depends. If there is a lot of them and they're very large and there's a lot of swelling, then I think we might have to do something. But it depends on the clinical situation. But if we can avoid it and we can start the therapy soon, and we can check again with another picture in maybe 4 to 6 weeks, I think we've had some good successes just watching.
So maybe Dr. Thawani, I'll go back to you. This might come off of your talk a little bit. I think we need maybe be very specific with which mutations, and maybe the list is too long to be able to spew through in one sentence. Do we have specific medications for that? If you were to find a person with this mutation, you have a drug for them and you would start them on this instead of standard chemotherapy or immunotherapy. Is that 3 different mutations in lung cancer, or is that like 25 now?
I think it's somewhere in the middle, but yeah, the list is growing every day. I think the most classic one is EGFR that we see the commonest mutation. So if there's an EGFR mutation that is targetable, there's certain EGFR that is targetable. So if that's the mutation that we have, then we do not offer immunotherapy at all. We offer targeted therapy right away.
And in the US, about how many of our patients present with an EGFR mutation?
Yeah, so it depends on the demographic. I would say a lot of non-smokers would be the ones who we would think, or remote smokers are the ones who we would classically feel are the ones with these EGFR mutations. They can be, so I would say majority of non-smokers would have one of these mutations or, genomic alterations that we have a pill for. And we do get surprises where we find patients who have a smoking history also have these mutations. So it's not exclusive, and that's why we wait for these results. But EGFR being the most common one, and then there are some fusions like ALK and ROS1, and we have the other targeted therapies we have are for BRAF, V600 mutations, we have NTRK fusions, we have NRG1 fusions that are in clinical trial. We have so many, I don't even know if I want to list them all.
But some mutations we don't have targets for.
Yes.
I mean,
Yeah.
now so many of our patients get those big, long reports,
Yeah.
and like 2 of the most common ones I always see on the top of the reports is KRAS and also P53. Do we have targets for those types of mutations?
Yeah, so KRAS is now targetable. One kind of KRAS is now targetable. It's still not used upfront. We still don't use pills for targeting KRAS G12C, which is a targetable kind of KRAS. It's still usually given after patients have progressed on standard of care chemotherapy and immunotherapy. The TP53 is probably one of the most commonly mutated gene in all cancers, including lung, so it's no different. I think if we're able to target TP53, I think we probably would not be having this discussion. I think
would have
people
cured
would
it,
do
huh?
really, really well, and we would probably have come to curing cancer. So I think we're far from it. There are some clinical trials on specific TP53 genes that that have drugs for it. We're really far from it. Those trials are still phase 1. People can Google it and find out. But I think we're far, far away from targeting TP53.
So even when we get that report that lists some things, that doesn't mean they all have a way to treat them.
Yeah, I think most cancers have mutations, and that's why normal cells become cancer cells. Not all of them are targetable. A select few are. The list is growing every day, but I think we're still, those reports are long. They're hard for patients to read, definitely. They're hard for oncologists to read sometimes. So I think getting an expert opinion and getting your reports and, seeking help from experts who have expertise in molecular oncology, I think definitely helps.
All right, Dr. Madariaga, we've spared you questions. So Dr. Hines talked a lot about, giving therapy up front before resections. It takes several months. Can people do prehabilitation while they're on therapy?
100%. So many of the prehab trials are just 2 to 4 weeks before surgery, but I would say that the longer you participate and focus on improving your functional capacity, there's no harm. And oftentimes, actually, people feel when they go through neoadjuvant therapy with chemotherapy, immunotherapy, they feel fatigued, depressed, they don't want to get out of bed, do their normal stuff. And prehab can actually help in those things. And some people have reported that actually participating in prehab makes them feel better. So I would say, as soon as you think that you need to have any sort of treatment for lung cancer or anything, start exercising.
So we need like our silver sneakers up on our infusion suite, right?
Yes.
In the chat, someone's asked a really good question, and I think it's not clear to people. We have all these fancy words. Is pulmonary rehab used in prehab? So is prehab and pulmonary rehab the same thing? What about if I had heart surgery and I have cardiac rehab? Is that the same thing?
Yeah, I think that's a really good question because prehab can right now be anything. There's a very big umbrella term for lots of things. So oftentimes when we say a patient needs to go to pulmonary rehab, we're talking about patients who have very bad lung disease, and then they need to go to a special facility where 2 or 3 times a week they get really pounded on with exercise. They're wearing oxygen, checking out their heart rate and make sure they're exercised to a certain level of heart rate capacity. So that's like cardiopulmonary rehab or prehab. When I talk about prehab, I'm talking about programs that you can do, whether they're at home-based or in hospital-based, supervised by physical therapy or supervised by yourself. They can comprise exercise, nutrition, psychological, mental preparation, taking care of all the other things around with your medication and medical history. And so those things are more geared towards making sure your functional status is optimized before surgery, meaning, you're doing what you want to do and just a little buffering up. And so that afterwards, when you take that hit of stress, because surgery is stressful, both for me and you guys, afterwards, you're able to bounce back from that stress and get back to what you want to do, whether it is running marathons, walking dogs, baking pies, whatever you want to do. We just want to protect that so you get back to baseline.
So is going out and walking for 10 or 20 minutes a day, is that prehab?
So I would say it's great if you can walk 10 or 20 minutes a day, but what's really important is to get a sense that you are exerting yourself. And so sometimes it's helpful to set a time limit of, let's say, and of some exercise, there are repetitions. One of the common things that we have people do is either march in place or chair sits to stands. So for example, if you set your timer for 30 seconds, and then you time how many chair sits to stand, so you're sitting on your chair and then you stand up, how many of those you can do in 30 seconds. And so that's your day one. And as you do that every day, and maybe you want to do it more than one time a day, you should try to increase that. And that focuses on your aerobic capacity, so aerobic exercise, endurance, and strength. So you're trying to kind of improve your overall cardiorespiratory function and fitness.
Thank you. All right, now I'll let you and Dr. Jalori argue this one out. So you both talked about, we talked about how we're adding chemotherapy and immunotherapy to both surgery and radiation, but surgery and radiation, those are both local therapies. Are those guys friends in the chest? Are they enemies in the chest? And how do we decide which local therapy we're going to use for a patient?
All friends. We're all friends. All friends. We're all friends. I think it really, I think it has to be personalized to the patient. Obviously we're very lucky to have Lucy here in all her efforts. And since she's come, I think the frailty testing is sort of carried on to other. I've noticed that our head and neck surgeons are using it now too. And so I think it's a good thing for all the disease sites that we treat for cancer patients here to really pay attention to that. So I think our philosophy is that if a patient can get surgery and we reasonably think that they can do well after surgery, after the walk test and the stair test and all the tests that, any test that we need to do, then I think they should get surgery. I think there are trials ongoing that are comparing the two. And I think it seems that SBRT is a very good treatment option as well in comparison to surgery. But ultimately it's the patient's decision too. And I think we've all seen these patients that can get a surgery, but really favor not getting a surgery, right? And then I think I have patients who never can get a surgery that really, really, really wish they could get a surgery. And I think it's our job to sort of help the patient decide what works best for them. And the nice thing is we've had a number of patients, including one we just finished treating that got surgery with Dr. Madriaga in December. And then I did the radiation for her other side because she had 2 different lung cancers in February. And now she's doing quite well. So go ahead, Dr. Madriaga.
So Dr. Madriaga, I'll let you tackle stage 3, because stage 3, when people have lymph nodes involved in the chest, some people get surgery, some people get radiation. How do you make that decision?
Well, I think with stage 3 disease, you kind of need to make a patient-specific recommendation based on how much disease they have and whether you think it's resectable. Sometimes with the lymph node involvement, it can be a little bit subjective about how much is too much lymph node involvement. But I would say that after discussing with your colleagues and seeing whether it's a resectable person, then having some neoadjuvant therapy and surgery would be the preferred approach.
Okay. All right. Now for the final set of questions. You're all going to get asked this on my little screen. I'm going to ask you the biggest hurdle you see right now in lung cancer care. And you get 1 second to answer. I'll start with you, Dr. Thawani. What's our biggest fight? What do we challenge with every day?
I don't get much time to think. Everyone else gets more time.
You're first on both of these, dude. You're it.
I think the biggest challenge, I think the biggest challenge is how do we prevent lung cancer? I think if we can stop lung cancer early on or screen it when it's really early, I think that is probably the biggest challenge. I think we'll save more lives, more patients will be cured, and I think in general the world will be better. And I think understanding how lung cancer develops and what is the right way to screen it, I think is probably the biggest challenge in lung cancer today.
All right, Dr. Hines, what do you think? What's our biggest hurdle every day?
I think it's just incorporating all this new information that's coming out, especially in this, we talk in the perioperative setting. How do we incorporate all these different trials and make these sort of best recommendations for our patients? I think it's the toughest part.
I agree with you right now. It's so fast. I can't keep up with all the new advancements. So it's exciting and challenging all at once as a provider, probably as a patient too. All right, Dr. Jaluri. Oop, I went out of order. Dr. Madriaga.
I agree with everyone's points also, but I think along the lines of the educational part is that we want to make sure all patients get access to all this cool new stuff, the biomarkers, the trials, and that's why education is important, because if you don't know what's there, then you don't know what to ask for, or if lots of people in different places, these things are not available to them. So I think access is important.
All right, Dr. Jaluri, what do you think the biggest hurdle is?
I agree with what everyone said. I think I would add that, we have all these very cool medications, now immunotherapy, targeted therapies, other stuff coming down the line, things like antibody drug conjugates and cellular therapies. I think one major challenge, for patients is knowing how long each individual patient has to be on the drug. I think right now we sort of just prescribe things for a certain amount of time, sort of how the trials were done, but in the future, I would really love us to be at a place where we know that, hey, I think it's okay for you to take a break now, or we can have better informed discussions about, well, I really think you should be on this for longer, and here's why. So that's hopefully we'll have that at some point in the future.
I think that's actually really true. We have never cured as many people as we are curing now, and especially in the stage 4 setting, where we've always just treated people till they died because most all of them died. Now that they're not dying, it's like, oh, do we stop? What do we do? Like we've never been here before in lung cancer, and it's a cool place. Dr. Garasino, can I ask you the same question?
Yeah, clearly everything that was said, I agree with all the comments. I think that maybe some treatments are still toxic. So I think that the best could be to have, the best treatments with the best quality of life and without the toxicity.
All right, now we're going to turn that same question in the other direction. And we're going to start in the same order. So, Dr. Thawani, you're on the hot seat again. That's what happens when you're the junior faculty. What gives you the most hope?
I think I think there's a bias in what my answer is going to be, and I think it's just because that's something that I study and understand the most. I think the more understanding of the genome we get, I think the better treatment and the better understanding of how the cancer developed and what we can do to stop it from growing and reverse it. So I think what excites me the most is reading that NGS report and seeing a hit there. It gives me a lot of excitement. I think it changes prognosis for patients, and I think more and more we're finding more and more markers, more and more is happening, more people are working on it. And I think what wakes me up in the morning and lets me get out of bed is like, maybe there's another marker today that that we will have a drug for, or that is being developed. And I think those are the kind of things that I'm most excited about in lung cancer.
Let me tell you, the way those press releases come out from the pharmaceutical companies, you do feel like every morning you could wake up and there's a new one. So I totally share your enthusiasm. All right, Dr. Hines, what makes you most excited in lung cancer treatment right now?
It's kind of the same answer, just like the rapid progression, all these new technologies. I remember being a fourth-year med student too long ago now, but in the in the lung
You're the youngest one on the panel, dude.
I know. in thoracic clinic, and I think it was just as like we're starting to use immunotherapies, and at the time patients were just like living, as we're talking about, just like a year, and now we're seeing patients years and years after, and I think just even in that short time span to see life expectancy increase for patients with lung cancer just gives me hope that we can keep that momentum moving forward.
Okay. Dr. Madriaga, what gives you hope for our lung cancer patients?
Well, I get hope from just talking to the patients. I think that there's such a strong lot that, they're willing to go through surgery and different treatments with us, that is very hopeful that we can solve things together. And then having great colleagues, everyone on this phone call.
Dr. Jalori?
I agree again with what everyone says. To add on to that, I would say that I think things like this and longevity, is it longevity or longevity?
Longevity, you got it.
There. All of the I think it's true for everything in life, right? There's just a lot more information now, and I think it's really good for patients and patients' families to have access to groups like these and others and patient advocates that we all know that are in the field of lung cancer now, that I think are A, informing clinical trials, and B, informing the way we talk about patients with cancer, and how we should be respectful. And C, really, I think bringing light to the fact that these, as Dr. Garasino talked about, we talk about these TKIs and these EGFR drugs and how they're so non-toxic compared to chemotherapy, but they're still toxic. And I think having our patients tell us these things and having this information and this open line of communication is a really good thing, and can only lead to more, to improved outcomes in the future.
Dr. Garasino, we get the last word. We're the old ones. We get the last things.
No, I think that what is very interesting is the multidisciplinarity. And this is the reason also why we are here together. And I see that we share cases all the time, we discuss all the time, we call each other all the time. That I think that to treat lung cancer patients, patients with lung cancer in 2024 is impossible without a big group behind.
Yeah, it is. It's a very complex cancer. There's no doubt about it. I don't know, I often have these discussions at some of our big cancer conferences. We treat vital organs next to vital organs by vital organs. And that makes treatment, challenging. We can't do what everyone can do in other cancers because of where we are. That's evidenced by what Dr. Jalori mentioned about, radiating the chest while giving these medicines. It just doesn't work for this cancer. I'm going to end with what I find most exciting right now and what gives me the most hope. I do think lung cancer was kept behind other cancers in the US and throughout the world in terms of research and cures for many years based upon things like stigma and bias and nihilism. And I think the greatest hope now is that we finally have survivors, and those survivors are such strong advocates for research and for this disease. And it is hard to be nihilistic when you look at, young people who are willing to fight for their lives. And I think having those faces to really stand up and say this is a disease that matters is the thing that's really going to change how the world views lung cancer and how we treat it. Well, I think this was a great discussion. I thank all of you for your expertise and the great discussion. And I'm going to turn this back over to our longevity team. And they are part of that wonderful face of what lung cancer patients and survivors and caregivers look like. And we can't thank them enough for all they do on that front.
Dr. Donnington, that was absolutely wonderful. Thank you to you and all of the experts on your team for that engaging discussion and for answering all those questions and for the very thorough presentations. We especially love that you ended with what gives you hope, because there is so much happening in the field of lung cancer research and treatment. We love on your website that you state today the outlook for a person with lung cancer is better than ever, thanks to better insights into the disease, new medicines, advanced technology, and less invasive surgery. It was so empowering to hear about many of those advancements from your team today. At this time, I'll provide an overview of Longevity's programs and resources for the lung cancer community. And thanks, Nahel. You can go to the next slide. So quickly, who we are. Through research, Longevity is using an innovative and holistic approach to finding lung cancer earlier when it is most treatable, advancing research into new treatments so people may live longer and better, and ensuring a diverse, vital pipeline of investigators for the future of the lung cancer field. Through advocacy, we foster groundbreaking collaborations to ensure all people have access to screening, biomarker testing, and treatment breakthroughs. Through community, we educate, support, and connect all people affected by lung cancer so that you can get the best health care and live longer and better lives. Next slide. Here are some things we provide. We are dedicated to funding scientific research because the link between research spending and improved survival is clear. Our strategic investment in both early detection and therapeutics will help people live better with lung cancer and dramatically improve survival rates. Longevity initiatives position us as thought leaders in the lung cancer advocacy community, providing programs and driving change for those with lung cancer today and in the future. While we fund primary research, we also conduct patient-focused research to better understand the unmet needs, and we convene multi-stakeholder meetings to streamline the research processes and accelerate progress to patients. So as Dr. Donnington mentioned, it really takes an entire team and lots of different organizations and healthcare providers coming together to drive these advancements and policy change. Longevity seeks to empower patients to be active decision makers in your treatment process through extensive educational resources, online peer support, and in-person survivorship programs. Next slide. So let's talk a bit about those educational materials. Lung Cancer 101 is your comprehensive guide to understanding the basics of lung cancer. You can learn how lung cancer develops, how it can be found, different types of lung cancer, and different treatment options, some of which were covered in the presentation today. We also have our Survivor and Caregiver Resource Centers, a clinical trial finder, and a video library available on our website. Longevity offers educational materials and support services to make a lung cancer diagnosis easier to understand for patients, caregivers, and advocates. Materials are available in English and Spanish, and materials can be downloaded for free from the website, or healthcare providers can order print copies for their clinics as well, if anyone joining us today is a healthcare provider. Next slide. Our patient gateways. When you know more about your disease, you can use what you've learned to talk with your doctor to decide the best treatment options for you and to make a treatment plan together. Through the patient gateways, you will be able to learn more about your type of lung cancer and get resources that help guide you through your experience. There are also tools that will help you find a specialist and clinical trial and connect you with other people with your type of lung cancer. Next slide. Our support and survivorship programs. The Lung Cancer Helpline offers toll-free personalized support for patients and caregivers at any time along your lung cancer journey. This is in partnership with Cancer Care. Our oncology social workers are fluent in both English and Spanish and are always available to help you manage your emotional, financial, and support challenges. You can see the number in the image on the screen. Through our Lifeline Support Partners program, we offer one-on-one support by matching patients and caregivers to mentors who have similar experiences. We also offer virtual meetups, which are moderated by patient services which make it easy to create friendships and support networks. We offer a range of meetups from general discussions to hosting expert speakers to our caregiver connection. You can visit our online longevity events calendar to find the schedule and see what works best for you. Next slide. Our survivorship conferences. Every spring, we are excited to host a unique weekend conference for patients with lung cancer, survivors, and caregivers to learn how to live with lung cancer while building their community of support. We're coming to Atlanta, Georgia this May from the 3rd to the 5th. Registration is open and we hope to see many of you there. The summit features expert speakers, breakout sessions, special evening activities, a patient resource fair, and children's programming, so please bring the whole family. The International Lung Cancer Survivorship Conference, ILCSC, is a free virtual educational conference which provides opportunities for attendees to hear from world-renowned researchers on the latest treatments, learn about ways to manage your lung cancer, and find hope in today's scientific progress. That's coming up this September, and that is virtual. And thank you again so much for joining us today. A special thank you to all of our esteemed speakers from UChicago Medicine. We are so grateful for your continued partnership and collaboration. And for all those who attended, your feedback is very important to us. We are sharing a link to a post-event survey in the chat. We'll also send the survey and a link to the recording to everyone who registered for this webinar. So you'll be able to rewatch, go back, take notes, catch anything you might have missed. If there are ways that we can support you, please visit us online at longevity.org or uchicagomedicine.org. You'll also see different ways you can connect with Longevity on social media. And if you'd want to reach out to our patient services team, the email address is hope@longevity.org. Thank you again to everyone who joined us, and thank you to all attendees. Take care, and we hope to see you all again soon.